Dr. Bella Mehta is a physician here at HSS who specializes in the care of patients with various rheumatic conditions, including rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, lupus, osteoarthritis, and she has a particular interest in adult onset Still's disease. Dr. Mehta is actively involved as an investigator in numerous clinical studies focusing on disparities in rheumatological diseases and has been the recipient of several awards for her research studies. Dr. Mehta's research reflects her commitment to achieving health equity, focusing on disparities in rheumatologic diseases. Dr. Mehta leads studies to identify and build creative approaches using big data to improve diagnoses and patient outcomes. She's an active member of associations for medical professionals in rheumatology. And with that, I know we are in excellent hands this evening for this presentation, and I will turn it over to Dr. Mehta. Thank you so much for joining us tonight.
Hi, thank you so much for inviting me and for your kind introduction. So I will get right into it, and I already see some questions coming in. We'll address them, some of them through this and some of them after in the Q&A. So what is arthritis? Arthritis is degeneration as well as inflammation of joints or tissues surrounding the joints. And the most common symptoms that patients come to us is with pain, redness, heat, or swelling of the joints. Osteoarthritis is probably the most common kind of arthritis, but there's 100 other rheumatic conditions that can affect joint and other tissues, and we do take care of all those patients. Some symptoms can develop gradually, while some are sudden. And, at least certain kinds of arthritis where it's autoimmune in origin, there can be systemic things, that is, many other organs or the immune system can be involved. So just going into the disease burden, 1 in 4 adults in the US have arthritis, at least diagnosed arthritis. That is 33 million US adults have osteoarthritis. Again, the bulk of arthritis, at least 98%, is going to be osteoarthritis. Again, why is it important and why do we care about it so much is because it is the leading cause of disability too. So today, around 58.5 million adults are diagnosed with arthritis, but in the upcoming 2 or 3 decades, it's just going to get worse. And around 23.7 million adults have arthritis attributable activity limitations. It could be as simple as, you want to go for a run and you can't, versus, activity limitations where you cannot walk up the stairs at all. So it's a range of things, but in the next 2 decades, around 35 million patients are expected to have these sort of limitations. Again, there's a high cost to this. Around 304 billion is the cost of arthritis, either directly with care or lost wages. And one thing that we know, and that's important, is physical activity, like movement, is the key to helping prevent arthritis and also improve symptoms in arthritis when you can. And we can go about talking about that in a little bit. So again, types of arthritis. The most common type of arthritis is osteoarthritis. Again, traditionally, it's thought to be degeneration or wear and tear, but there is an inflammatory component to it too. And the others listed here, like rheumatoid arthritis or seronegative arthritis, like psoriatic arthritis or ankylosing spondylitis, reactive arthritis or enteropathic arthritis, all of these kinds of seronegative arthritis are also inflammatory origin. Whereas post-traumatic arthritis, as the name suggests, happens a lot in people who've had like injuries, ACLs, MCLs, and maybe had a meniscus tear. And then these are patients who have accelerated arthritis at a much earlier age. Gout is another issue which causes joint inflammation and pain. So again, osteoarthritis we've talked about. It's the most common kind of arthritis. It can affect are a lot of joints in the body. The most common ones are the hips, the knees, the spine, and the hand. Again, like I said, traditionally it's thought to be wear and tear. I don't know if you can see my mouse, but if you can, here you see the articular cartilage, meniscus. It's all smooth, and there's like some space between the thigh, and this is the lower leg, and you can see there's some space between the two joints. So when there's like articulation or movement, where you bend the knee back and forth, the articular cartilage is smooth and allows that movement. In osteoarthritis, there is all this degeneration. The one big thing that is always talked about is cartilage loss. So instead of the smooth and glistening cartilage, you see there's like small holes punched in this, and this is just a cartoon to depict what's happening there. And then there's bone spurs or small pieces of bones which are around the joint, which are looking abnormal. They also sometimes get chipped. Osteophytes is what they call sometimes. And then because of the cartilage loss and whatever's happening to the joint space becomes narrow. So there is less space for that smooth movement of the knee to occur, for example, in this figure. So, what are the symptoms that most patients come to us with? Joint pain that is worse with use and relieved with rest. So, when somebody is lying down, they feel better, or a prolonged few days of rest, things get a little better. Tenderness, that is when somebody touches the joint, there's pain, there's stiffness, there's swelling, bony swelling, which is sometimes very obvious in the knees or the hands, which are things that you can visualize easily. Joint instability, sometimes patients complain of like, feeling like the knee will give in. Also, functional limitations. Again, clicking or cracking sounds, slow onset of symptoms. There's some asymmetry, stiffness, pain. Bone spurs are usually seen on X-rays, but sometimes some people can even feel them. And lastly, reduced flexibility. That's one big one. Like, patients can't do the same things that they were able to a little time ago. Again, the common sites we already talked about, the knees. Most of the pain that patients may complain of is weight-bearing joints, but sometimes even hands, especially in women. Hand OA is very common and patients complain of it. One thing about hips is usually it's only one side which is worse than the other, whereas knees, sometimes it's both, but most patients complain of one side, which is worse. Spine, again, there's degeneration of multiple joints there, and that can get severe enough that it even compresses the nerves sometimes. So if that's the case, most primary cares or most physician, somebody will tell you to see a physician right away. And again, hand osteoarthritis is usually bilateral. In a lot of older women, especially, you'd see some visual changes in the hands, and we can go over that too. So what groups are most likely to develop osteoarthritis? The first thing, and sort of going on the theme here, is women are more likely to have arthritis than men. Again, the likelihood of arthritis itself is so much higher, but women are most affected by it, not only in terms of the diagnosis, but also the amount of pain that they experience. The second thing is arthritis is increased with increasing age. As we all know, younger patients have much more sort of regenerating properties, and senescence is sort of a newer concept even within osteoarthritis that people are talking about. So the cells don't heal the way they used to, and that's why there's more degeneration in osteoarthritis. The other thing that is, again, I do a lot of work on disparities. So, socioeconomic status also influences osteoarthritis rates. And again, this could be a function of multiple different things that the socioeconomic status might reflect. It depends on which area also. So, New Yorkers may behave a little differently than, say, some other cities. But overall, a lower socioeconomic status leads to worse outcomes. Again, there's racial and ethnic differences too. non-Hispanic Black patients, non-Hispanic white patients are more likely to have arthritis than Hispanic and Asian non-Hispanic adults. This sort of also proves that there's some genetic component to it more than, or which plays a role along with some of the other factors that we study. Percent of arthritis is increased with urbanization, probably because of lack of exercise or more diagnosis happening. So there's multiple ways to look at it, but again, we're talking, most of us here are in an urban setting, and the risk is definitely higher. So let's talk about why women have more osteoarthritis. So this is this is something that a question that has been in my on my mind for a long time, and we currently have studies enrolling for these, but what we're trying to figure out is what is there modifiable factors. But coming back to it, what are the factors in women? One is weight, there's anatomy, there's hormones, there's sports and social and societal differences. So we'll get into that a little more. So weight seems to be playing a major role in development of osteoarthritis in women. It's already known, weight is already known to be a strongest risk factor in OA for both men and women. And extra weight increases joint stress, and also inflammation burden in patients is also triggered by this. Again, patients, at least women, start complaining of seeing some of these effects around menopause, and that could be a function of many things, changes in hormones, but also weight gain. And again, they're trying some of the newer drugs like Ozempic or GLP-1 inhibitors in osteoarthritis. But most of it, I think, most of the effects that they're seeing is weight related more than the drug itself causing something to osteoarthritis. The other thing is anatomy. So women overall have wider hips. The reason they have it is anatomically designed so that they can probably deliver babies. So the women's hips are wider, so the alignment is different. So the weight distribution on the hip and the knee joints are different. Thus, women are also more likely to develop something called patellofemoral syndrome, where there's pain over the kneecap. And again, that's a function of anatomy. That's how it is designed. And that's why women probably need much more exercise to prevent patellofemoral syndrome, or if you have it, to alleviate symptoms, because you need to strengthen the muscles around the knee joint and the thigh muscle much more. Again, bone alignment, joint looseness, and muscle strength are also factors that play a role. And again, one thing that we know is that when you have a higher BMI, the women lose cartilage even faster than men. Again, this is a function of multiple things. We cannot point out to one thing, but all it says is that there's many ways to sort of deal with this and prevent this or take care of the symptoms when you have them. Also, female athletes are known to have higher rates of ACL injuries, which we know increase post-traumatic osteoarthritis. So much younger females start getting osteoarthritis because if they've had ACL tears. So the next one is a big one. It's hormones. Hormonal changes may explain the women's higher risk of osteoarthritis, especially around menopause, like the estrogen, progesterone, all of the levels change. Also, during pregnancy, there are these hormones that are secreted so that the pelvis, which is supposed to expand for the baby to pass through, in theory, also may increase joint looseness overall in the body, and that may cause problems. Menopause is a critical time for women's bodies. Firstly, they're aging also, and there's many changes happening at that time, and that's when some of these osteoarthritis risk and triggers happen. So very important to keep moving, keep exercising at that point. Estrogen and other hormones may affect inflammation and cartilage health. And I saw the first question on the webinar talking about like HRT for or hormone replacement therapy for osteoarthritis. At least at this point, all the societies say that you shouldn't be doing HRT specifically or hormone replacement therapy specifically for OA, but you could do it if the patients have other symptoms, and then it may help osteoarthritis too. So again, the societal and social factors also make a huge impact on this. Financial resources, support systems, access to care, everything influence OA outcomes. One thing that is known in the literature is women often delay joint replacements, maybe because they're caregivers and they're taking care of their partners or whatnot. But on an average, women delay joint replacement with the same amount of pain or damage, or in whatever way you look at it, than men, because of social and societal factors, essentially. Again, we talked about this, like menopause increases osteoarthritis risk, but activity helps protect the joint. Muscle and bone loss is very, very crucial at this point. One thing that I always recommend is, one is staying active, and then make sure that you have enough calcium in the diet, because that's post-menopause you start having a lot more bone loss. Again, bone loss directly doesn't relate to osteoarthritis, but it may affect it. So what exercises are effective during menopause? Mind body exercises, whatever works. I mean, I tell patients like whatever works for them. Each individual patient is different. Tai Chi, yoga, Pilates. I mean, whatever can be worked in your schedule and life. Exercise, particularly strength training, can help reduce some symptoms and potentially slow progression. And again, I would not recommend anybody to do like any exercises which they think are stretching their body too much. So high impact exercises probably are okay for certain patients, but not for most. This is sort of like aim 2.5 hours of moderate aerobic exercise and resistant training at least 3 times a week, as in a total of 2.5 hours in the week. How do you treat osteoarthritis, right? Like once you have it, patients will have symptoms. Well, one is definitely avoid joint trauma. Athletes, certain dancers, certain professions, you can't skip it. You just try and do everything preventative. One thing that I feel have been game changer and probably not utilized as much is knee braces. Something like a simple neoprene sleeve that you get at any drugstore. You can just do it on bad days, and then that helps. Walking aids, whatever it may be, as long as you know how to use them well. Orthotic shoes are also great, especially because some patients, when they start developing osteoarthritis, they have either knock knees or their knees start bowing. So the orthotic shoes help correct that without any big intervention. TENS units sometimes helps, at least in the short term. It's not really recommended by ACR or any of these societies, but patients like it. It is low risk. You can get it online somewhere and people use it. So if it works for you, great. Acupuncture, again, there's a lot of people do it. There's not much clinical data on this, but it's out there. So again, I think that osteoarthritis management is mainly non-pharmacological, like working with physical therapy, occupational therapy is great. It's like the key to all of this. Now, what are the medications that one can do? NSAIDs like Motrin, Advil, Aleve, whatever works for you. But again, talk to your primary care. Make sure that it's not affecting your heart, kidney, or stomach health. Most patients do okay, but you need to consult with your doctor to make sure you can take it for an extended period of time. Some of my patients have been taking it for years and they are fine, but somebody's monitoring their metrics. Cymbalta, which is the brand name, or duloxetine, is approved for knee osteoarthritis. Does work wonders for some patients. So that's something to ask your physician. It's prescription only. And there's topical options. I mean, things like Voltaren gel, now that is over the counter, or like even Icy Hot or Bengay or any of that. On bad days, those are the things that can get you through. Caspacin also for localized pain. Again, we talked about hormones or hormone replacement therapy. It's not recommended to do just for the joints, but if there's other reasons for it, it may help the joint. chondroitin sulfate and glucosamine, the evidence is mixed. Actually, most of the guidelines now don't recommend it. Sometimes patients insist on trying it. It doesn't hurt them, but it's definitely something expensive which may not work for most patients. Injections for patients with very severe pain, glucocorticoids or steroid injections are tried, and they work well for short periods. We do that when patients are in a lot of pain, getting through some big event, works for a few months, or maybe they're trying to delay surgery. Hyaluronic acid has similar efficacy to steroids, but it's much more expensive. So between hyaluronic acid or like some of what they call as gel injections, Simvisc and whatnot, between that and glucocorticoids, I think they work the same. There's enough evidence for that it works the same as steroids. So steroids are cheaper. You just do it locally. They don't go all the way in the body and create those side effects. So it's a cheap and effective solution to this. And lastly, again, surgical. When osteoarthritis is advanced, joint replacement surgery may be a good option to restore function. Again, if only one side of your joint is worse, they do like what they call as partial knee replacements in this case. And then this is a total knee replacement where the whole joint is replaced. Here it's a metal, but there could be ceramic or any of those components that come in. Typically, you try all the other options. If they don't work, then you go in for surgeries. But these are very effective surgeries too. They are elective, and patients usually get a lot of their function back and the pain resolved. With that, thank you, and I'm happy to take questions.
Excellent. Thank you so much, Dr. Mehta, for this really incredible overview of osteoarthritis, especially highlighting osteoarthritis in women and some causes. We have a variety of questions coming in that I'm going to kind of break up into a few different sections. First, I'd like to focus on the questions coming in that are around women and women's health specifically. So one interesting question came in: does a woman's age when they give birth make a difference on when they might get osteoarthritis? Is there any research on that, or do you see any correlations in practice?
I don't. That's a very good question. I don't think it matters as much. There's no data on that, to be fair, but you know, depending on how the pregnancy goes is a bigger question than what age in a way for women. Because it's all premenopausal, so we still group it under one thing,
Mm.
essentially.
Right. But in terms of like how the pregnancy goes, so if it was a challenging pregnancy or maybe like, you couldn't be as mobile during that time, that could potentially impact when or
Yeah.
how you get
Yes.
osteoarthritis. Another question regarding testing hormones. Is your team or others testing hormones in those with arthritis and those with not to track possible differences in groups? Is there any research going on
So
at
there is
that?
there's like lots of large data set studies on this, and the unfortunately the data or the outcomes from them are mixed, right? Because there's a lot of bias on who has these hormone replacement therapies. So that's why there's no conclusion or recommended guidelines on that.
What about any research showing HRT, hormone replacement therapy, it can improve joint, tendon pain, and stiffness in perimenopausal women?
Again, the data is mixed, so we don't know. Again, we would not just give HRT for pain or osteoarthritis. If the patient has other indications for it, then it's okay.
Yeah, it seems like a lot of OA treatment is trying, you're starting with some self-management, trying the NSAIDs or medications. There are a few questions about OA progression and how the disease progresses. So some people have noted that they've tried exercise, they've tried physical therapy, they've tried gel shots, and they're still having pain. So when do you counsel your patients to maybe see an orthopedic surgeon?
I think that's a very good question because there are some patients, firstly, you want to make sure that they've done the right physical therapy, right? Exercising, the right physical therapy, as in sort of targeting uh, sometimes just exercising at home, maybe you're not doing the right exercises. So as long as you've done it to strengthen muscles around the joints and above the joint and below the joint, that should be good. Then the second thing is I tell my patients when they have intermittent and constant pain. So some patients who have intermittent bouts of pain and then they are fine otherwise, I wouldn't necessarily want that patient to go to a surgeon. But when a patient starts having this low grade but constant pain or function loss, some people don't have pain, but like they come to me saying, I just can't do stairs anymore. I mean, maybe when there's a constant, right? That's when I refer, constant of anything, that's when I refer them to surgery. And again, depends. Like if there's a high functioning athlete who needs to run a marathon, then they probably need a surgery much more, depending on what your activity goals are too.
Mhm. Absolutely. And so the idea is that if it is impacting you regularly on a day-to-day basis, maybe escalating a bit if what you're doing at home. Um, and this question is kind of along the same lines. Can OA be effectively managed by a general practitioner, or should patients see a rheumatologist or a specialist? And what would be the advantages of seeing a specialist if you recommend it?
Yeah, I mean, so again, it's millions of patients who have osteoarthritis. We're working on getting new lines of treatment for OA, but we don't have many right now. Most of the medications or non-pharmacological treatment that I talked about can be done by PCPs. Again, the reason I would say to see rheumatology is to rule out other inflammatory arthritis that we have, like rheumatoid arthritis or um, so when something is out of the normal for OA, and usually like PCPs can detect that, that's the time to see a specialist. Also, when the pain or something is getting worse, maybe a physiatrist. There's many people who manage osteoarthritis, starting with primary care, physiatry, rheumatology, physical therapy, orthopedic surgeons, and many more, honestly. So it depends on uh, you know, not everybody needs to see a rheumatologist or a specialist all the time. But when something's out of the normal or when there's a change in event, for example, now suddenly you have some sort of constant pain or something, that's when you want to see a surgeon or that's when you want to see a specialist to evaluate.
Right, right, absolutely. I think that's really good advice. If something changes, if something's affecting your life constantly, then you want to take care of yourself. Um, in addition, the same kind of questions about stopping the progression or about the progression of osteoarthritis. Someone's asking about stopping the progression of osteoarthritis. Is there anything else that you would add? I know we talked about exercise. Um, like, does
Weight
anything actually
loss.
stop the progression or just manage the symptoms?
There is some patients who have degeneration of the joints may have no symptoms. Okay. So there is sort of a thin line there. But weight loss is definitely something that is proven to stop the progression. Even just overall maintaining a healthy lifestyle, which is, appropriate weight, adequate nutritional diet, and exercise uh, is known to help osteoarthritis. We don't have a precision medicine approach to it yet to stop progression. We are working on it. We have studies and trials that we are launching, but again, none of it is ready for prime time.
Right. That's a good segue to and the next kind of set of questions. We've gotten a lot of questions about recommended nutrition, foods to avoid, foods to eat. I'm going to take this moment just to plug a program that we have coming up on nutrition for osteoarthritis. That's coming up. I will share the details at the end of this Q&A. But in the meantime, Dr. Mehta, is there any general advice that you give to patients around nutrition, especially if they're experiencing joint pain, stiffness, symptoms of osteoarthritis?
Yeah, I think the plug is great because that's a 1 hour or 45-minute dive into that. But my big takeaways is overall maintain a healthy diet with adequate macro and micronutrients, protein and fiber, especially to be taken care of because women uh, generally lack that or the diets lack it sometimes.
Yeah, and diet, especially for women, um, can kind of go to the wayside, especially if you're taking care of family, you're taking care of partners, of children. Maybe you're not caring about yourself as much, or you don't have the time to care about yourself as much. And so diet can really become a big factor. And we'll talk all about it on October 8th is that program, and I'll share those details again. Um, there's some questions about OA and osteoporosis. Is
Mhm.
there any correlation between those? And I know osteoporosis does affect women as well with bone density. So can you kind of speak to that?
So osteoporosis is where the bones itself become weaker. When we talk about osteoarthritis, we're talking mostly about the joints. And when we talk about osteoporosis, it's the entire bony structure. Again, osteoporosis is something that is way more hormone related, way more calcium related compared to osteoarthritis. Is there a direct link? Probably not exactly, but like very bad osteoporosis will lead to osteoarthritis. So, uh, and again, it's the end of the day. You if you take care of the bone health, then the joint health will be better. So again, for women, especially postmenopausal, having adequate calcium intake, vitamin D is so important because calcium also helps the muscles function right, which helps the joints function and move properly. So it's like a cycle.
Yeah, absolutely. It's all connected. It's all connected. There are some questions about medications. And so one is about meloxicam and taking meloxicam for an extended period of time. What are your impressions on that?
Yeah, meloxicam is an NSAID, which is like Aleve, Motrin. They're all cousins under the same sort of hood. Aleve, Motrin, um, ibuprofen, whatever you call it. So again, some patients need it for various diseases, including arthritis, and it is okay to take it for extended period of time as long as somebody is monitoring you, as long as you don't have other cardiac, renal, or stomach problems with it. So again, as long as you're seeing a primary care who's assessing you regularly and is saying, okay, you can take it.
Great, great. And I know it does provide a lot of people relief. And so that's helpful to know that it
I
is.
mean, I've had patients who've had certain kind of arthritis who've been on it for 20 to 30 years. So it's okay to be on it. You need to be monitored, make sure there's nothing going, there's no side problems with it.
Abs Absolutely, absolutely. Um, Another question regarding medications I actually think is interesting. The question is around Cymbalta and Cymbalta
Mm.
treating osteoarthritis, but this participant's also asking if it could potentially help with mood changes during menopause as well.
It does, right? That's why it's a great medication. It's underutilized in osteoarthritis care, I feel like, because it's been approved for so many years for knee osteoarthritis, but not as much. There's not as much uptake because I think that there's a taboo. A lot of I mean, it comes with a name tag that it's a psychiatric medication, right? Uh, but it helps with multiple things. It basically works on the nerves. It's what we call an SNRI. So some people don't want to take it, saying this is a psychiatric medication, but it's not for that purpose in certain patients. But it can help with mood. It can help with overall body aches and pains, and for patients who tolerate it, they do dramatically well with it. So it's worth a try for patients.
That's great. I mean, um, is it, you think, underutilized just because of the stigma that comes along with it? Yeah.
And I think Yes, there's a huge stigma that comes along with it. I feel like, especially for women, right? Like you're going through so much perimenopausal, and then also there, not many physicians are aware of its use in osteoarthritis, and that's like a double-edged sword.
Yeah, yeah, absolutely. I didn't know until your presentation that it was recommended for osteoarthritis. So that's so interesting. Um, okay, a couple more questions about women's health. Is hyaluronic acid injections contraindicated for women with a history of breast cancer? Or are there any other considerations maybe that women should be contraindications for women in terms of injections?
No, for hormone replacement therapy, yes. Do you have to talk to your oncologist and make sure, that it's okay? But hyaluronic acid injections are the gel injections that they call, they're usually local and they stay in the joint. So there's very little contraindications to it. But again, I want to plug here saying that it's a relatively expensive drug for something that a steroid shot does the same thing. The efficacy is the same. So I usually try the steroid shots, and if there's some issues or contraindications or like you can't give it for this reason, then I go to the gel shots. But again, different practices do it differently.
Yeah, yeah, that's good to know. Absolutely good to know. And then I have two more questions to wrap us up. So, would having an autoimmune disease like psoriatic arthritis or rheumatoid arthritis have any impact on being more susceptible to getting osteoarthritis?
Absolutely, absolutely. So having an autoimmune disease, your joints, and especially because autoimmune disease, the immune system is also attacking your joints. In addition to all the risk factors we talked about, right? So the joint damage in patients with autoimmune disease is much faster in a way. So those are younger patients getting knee replacements or hip replacements or whatnot. The goal is to keep the inflammation off. Um, Psoriatic arthritis or whatever the condition is in control so that the damage is prevented or delayed.
That's really good to know, especially for those participants out there that might have an autoimmune condition to kind of keep an eye on their joints in other ways as well. And then just to close us out, what are some new developments in the field that you're excited about in terms of your ability to care for patients with joint diseases?
I mean, there's phase 2 and phase 3 trials of new agents. So all of these things that I talked about, either non-pharmacological or pharmacological. Pharmacological is mainly after the fact, or they're band-aids to help with pain. In the back in the day, they even gave opiates for this, but now it's not recommended. Um, but there are newer drugs out there which will hopefully stop the progression of osteoarthritis. At least they show promising early results. They're not even ready for like really enrolling patients for trial. They're phase 2 or maybe early phase 3. But I think in the next decade we will see these drugs come in and change how we treat osteoarthritis. So then I'm just excited that there's options to offer because at this point, you do manage the pain, you do exercise, and the worst case, you do a joint replacement. We don't have, you know, 10 other drugs for this. I wish we had, and I think in the next decade we will.
Absolutely. Dr. Mehta, thank you so much for all of these incredible insights.